recurrent miscarriages are spontaneous pregnancy losses before the fetus reaches viability. And the definition varies. With ESHRE consensus, it says 2 or more pregnancy losses. And on the SASWAG website, ASRM and the Green Top guidelines, it says 3 or more pregnancy losses. But they say that you may proceed with tests after 2 losses. Now, I just want to know if there are people in the room who've had miscarriages. Yeah. So would you like your doctor to test after the first one, the second one, the third one? Yes. I actually lean more towards the extra consensus, and even after the first one, it would be worth checking given the fact that people are conceiving later. That's my opinion. It's not the literature. Because when you encounter people with miscarriages, the loss is absolute for them. So it's not like you're waiting for the second one and the third one, then you're going to test. It doesn't work that way. Because then after the first one, they're still not sure if they can carry the pregnancy in the second try. So again, there's a statistic that it affects 1 to 2% of couples. Now, probably never. But are we going to get to only 1 and never more? I'm not sure, because I feel like someone has to fulfill the statistic always. So that's another. I don't have a reason why you had a miscarriage, and 50% of the cases are known anyway. They look at you like you've stabbed them with a spoon. Like, you can't tell me you don't know. But that's how it works, because then they're not sure if they'll ever know why they had a miscarriage. There are known causes, starting with the embryo. There could be random genetic mutations, and these are associated with advancing parental age, lifestyle, and a higher BMI. Or the embryo could develop abnormally, like spina bifida or heart problems. And those are probably related more to deficiencies or even lifestyle, especially spina bifida. And then there's parental chromosomes that the geneticists spoke about, translocations. I met a patient with 13 recurrent miscarriages. She was pregnant for the 14th time. Eventually, they found a translocation. And eventually, in that pregnancy, she carried to term. There are endocrine factors, thyroid abnormalities, hyperprolactinemia, which are treatable. The risk of miscarriage in women with polycystic ovary is high because of the metabolic influence, diabetes, and luteal phase progesterone. And then there's thrombophilia. So they say with hereditary, there's a very weak association, and you will see later the recommendation is and there's acquired, which is antiphospholipid syndrome. Then there's a long list of anatomical factors and other factors. The uterine factors are congenital or acquired. With the congenital causes, a septum. Now this is controversial, and you will see as I proceed with the talk. With the uterine septum, it's very interesting. I had a patient who had heavy menstrual bleeding. She wanted an ablation, and she had 3 children, And she had a huge septum. And I'm like, you never had a miscarriage? She said, no. And recently I had a patient who's had recurrent miscarriages, recurrent failed IVFs. And when you scan her with a 2D scan, you think, okay, everything looks fine. And I said, no, let's do a hysteroscope. And lo and behold, she had a complete septum, and in fact, the one cavity was larger than the other, overshadowing the smaller cavity. So we opened up we removed the septum. So, and all this time, it was not picked up. It's very interesting. And even on scan, you couldn't see it because it's as if the other cavity had collapsed. But having had so many miscarriages and so many failed IVFs, it was the right thing to remove it. And I had the fortune of having a patient with a didelphys. It's a condition where you have 2 separate uteri, 2 cervices and 1 vagina. This lady came, she was bleeding. We were concerned that she's having a miscarriage. Turns out she conceived on both uteri. She had a smaller cavity and a larger cavity, a smaller uterus and a larger uterus, each one with its own tube. And in the smaller cavity, she miscarried, but in the larger cavity, the pregnancy continued. Obviously, she delivered prematurely, 28 weeks, because of the size of the uterus. But I thought that was interesting. And she said to me, can you please put them together? I'm like, no, it's not, doesn't work that way. So luckily, she has live children. And then you can have a unicornuate uterus. Usually this uterus is small in size. With the acquired uterine conditions, the cervical insufficiency, the cervix, some people see it as a standalone, but it is the terminal end of the uterus, the lower part of the uterus. I don't know if the audience is aware of cervical insufficiency. It used to be called incompetence. That was not a politically correct term. It had to be changed to insufficiency because it's a spectrum. The endometrium can have fibroids, can have polyps, can have adhesions, and can have chronic infection or inflammation. And those can be addressed. The uterus also can have fibroids that are not in the cavity but are impacting the endometrium. And if the embryo implants in such an area where a fibroid is close to the endometrium, there may be a failure for implantation. So that can be a factor, but you will see with recommendations it's also a controversial issue. Endometriosis, also we know endometriosis is an inflammatory condition and it's a chronic one, and the physiology is abnormal, the anatomy is abnormal. And it's a long topic, I'm not going to get into it. There's adenomyosis. For those who don't know adenomyosis or who don't go to Google, it is a condition where the inner lining of the womb is forming clusters of glands in the muscle of the uterus. In most cases, when you scan such patients, you'll find a normal-sized or slightly enlarged uterus. Then you can see clusters of glands in the uterus, or sometimes it can be diffuse, in which case it can be difficult to deal with. When I say diffuse, I mean it can be all around the uterus. And then there's an old drug that women had been exposed to, DES, diethyl something progesterone. It's a long name. You don't have to know it. I think the last time I saw a cavity that was affected by DES, I was a registrar. I had the fortune of seeing that. Of course, infections, which we don't see a lot anymore. Another controversial issue is whether we should treat or even screen for vaginal microbes, the atypical bacteria, GBS, bacterial vaginosis, that's hanging. We do storch. It used to be called storch or torches, which is syphilis, toxoplasmosis, CMV, rubella, chlamydia, of course, and herpes. So what are the risks? If you've had a previous miscarriages, and this include a choice of termination of pregnancy, you have a subsequent risk of a miscarriage. And usually the miscarriage happens at or prior to the previous miscarriage in terms of gestational age. So the recurrence risk increases with each subsequent miscarriage. So that's when I say that it's a bit discouraging, but obviously you have to, test and walk the path with the patient. And then there's advancing parental age, and in women more than 35 and in men over 40. And the BMI, low BMI patients, beware. Those patients with BMIs, and I've seen patients with BMI of 17, and I said, no, you have to gain weight a little bit, and we can talk when you've gained weight. So even the patients with higher BMI, you say, okay, we do want you to fall pregnant, but we don't want you to kill you in the process. And but most patients who've had miscarriages usually do try to modify their lifestyle to prepare for the subsequent pregnancy. Obviously, smoking, including cannabis. Cannabis does affect sperm parameters, all sperm parameters. And I want men to be aware of this because they are now freely available over the counter. Alcohol, and I put the excessive exercise. And when I say excessive, I mean the people that are running ultra marathons. If you're an ultra marathon person, I think when you do want to conceive, you have to maybe go to the lower distances, because when you train like that, you tell your brain, I don't have time to fall pregnant, and you then can have a condition called hypothalamic amenorrhea. And they say stress does play a role, and they say it's a weak association. I'm not sure, because stress is relative from one person to another, that our tolerance you would consider stressful for one person is not. So maybe that's why they say there's a weak association. So just to show you in a table form, if you've had the risk of your miscarriage, especially in the first trimester, is up to 13% in your first pregnancy before you even miscarry. So I always tell the patients, if we reach 13%, we more and more remote from a risk of miscarriage. 13 weeks. After the first miscarriage, it ramps up to 21%, and then third, 29%. And after the third one, almost half of the women will miscarry. After the third miscarriage, they'll have the fourth one, which is really heartbreaking. Again, I just want to say, for women that are over 35, the risk ranges from 24% to 93%, which is really, and there are women who are over 45 who still want to conceive as long as they are. So usually people will skip the slide and put it at the back, but I wanted to start with it because the doctor is always confronted with a distressed couple. Usually the the patients are feeling that they have lost a child, and you have to address the loss, and you have to use clear language, and you cannot say you had an abortion, because in a medical textbook it would say abortion. You'll say you've had a miscarriage, you've had a pregnancy loss. So you have to use sensitive language. You have to also mirror the patient, because for the patient it's like, oh, we've lost the child. Even if they were 6 weeks pregnant, anything from the time the pregnancy was confirmed to near viability, to the patient, that's a child. So you have to actually acknowledge that, and you have to be honest about their chances in future. If you know there's a condition you can change or not change, and not say, oh, things are going to be fine, you'll have another normal pregnancy. You just have to say, it happens, let's test, let's see how we can prevent it in the subsequent pregnancy. And you have to work with the patient, not work alone, and say, go and do the test. Usually the patient don't know why they are doing the test. It's good to explain the test to the patient, say, I'm doing this test because. So, and you have to give supportive care in the subsequent pregnancies. And I had a patient who had a miscarriage, and it was a late miscarriage and close to that gestation. And she had antiphospholipid syndrome. I knew I gave her everything to prevent. But I will tell you, when she reached around 24 weeks, she was petrified. She said, please admit me. I don't want to lose this pregnancy. So I had to reassure her that she will not. And she did have a safe term delivery. And you have to be kind. And, we see a lot of patients, and sometimes, you're tired. When a patient is distressed, you have to actually also go into their emotional state and say, I feel your pain, and this is what I'm suggesting. So what are the investigations? These are to the guideline development group. You can find them in the extra website. So you take the history, and a genetic analysis of tissue is not recommended, but it can be performed for explanation. And they recommend RACGH because of risk of reduced maternal contamination. Where's the geneticist? What do you guys do?
We do next generation sequencing. So
NGS,
NGS arrays in South Africa are still quite expensive, so it's not the technology that's generally used for this kind of testing.
Yeah. So is NGS cheaper?
NGS, yeah.
Okay. And what about the maternal contamination?
So there are ways that we can reduce the risk of that. So the tissue is assessed very carefully to determine whether it's placental, chronic villi, or fetal, and that will usually be discussed with the clinician if they're not sure where the tissue is from. But there are also tests that you can do to specifically check for maternal cell contamination.
Okay. Is it worth actually the cost?
I'm biased because I think it is, but the reason why is because I feel like the emotional and psychological value that it provides to the couple who's experienced the loss is very important, and that's why it's not going to be the same for every patient. I feel like for some couples, knowing why they may have experienced a loss is really valuable. And there are a lot of things to consider. The finances are one thing. Sometimes it may be covered by medical aid. That all varies from couple and patients. But personally, having seen many patients who've experienced losses, knowing why something may have happened is really, really valuable. So I think it is.
Okay, there you have it. So they say parental karyotyping is not routinely recommended, although I've had patients that have requested it. We don't screen for inherited thrombophilia unless there are additional risk factors. we definitely must screen for antiphospholipid syndrome, and the recommendations all say after 2 miscarriages. From the doctors, do you check after the first miscarriage or after the second or after the third?
It depends. Usually second. Yeah, usually second.
Usually second, not after the first.
That's why I'm saying it depends.
Okay.
Yeah.
All right.
We would have to discuss with the patient.
Thyroid screening is really easy. It's just a lab test, and it's also easy to manage. Polycystic ovarian syndrome bloods really do not contribute because we know the diagnosis already, and we know the pathophysiology. Prolactin, if there are clinical symptoms of hyperprolactinemia, you can test for that, but I find that controversial. I had a patient that's also had several losses. And when I tested, I saw that she had hyperprolactinemia, and she said, you know, she's told every doctor she has galactorrhea, meaning she's expressing milk at least in one breast, but no one really checked or thought it was important. And so, you know, I looked for all the causes of the hyperprolactinemia. So it looks like it's just idiopathic hyperprolactinemia. I couldn't find the reason why, including the MRI scan was done. Then you have to assess the uterine cavity. If you don't have any of this, but most doctors do, and you are in a remote area, you can do an HSG, but it is inferior to the other modalities. If there are uterine abnormalities, malformations, you then have to look for other pelvic abnormalities, kidneys, and the urinary tract anatomy. Lifestyle factors, again, I think I have to agree that I have found that they contribute more than any other factor that I can put forth. Lifestyle factors really contribute. I mean, I'm an IVF specialist, and this is an IVF story. We had 14 beautiful eggs, 3 embryos, bad quality, because the sperm was just such poor quality. And the gentleman was working for a big company, a football club, and they had parties and whatever every so often. So I said, if you really do want a child, you're gonna have to cut out drinking. And subsequently, and it was good because, you know, we could say, if you stop your drinking, you could improve the sperm parameters, you might get more embryos. And in the subsequent cycle, they did fall pregnant. So you see this a lot with IVF. It's, I mean, a bit difficult when patients can conceive spontaneously. Because some patients will say, yeah, but everybody is walking around, and that woman is smoking, and that one is drinking. Why me? But we don't have the same genetics, we don't have the same physiology, we don't have the same anatomy. And we're still not sure about sperm DNA fragmentation, if it's contributory or not. I said that it's easy to test for thyroid, and the guidelines are very clear. We're not sure if we should be treating subclinical hypothyroidism. Do doctors treat this?
What happens with miscarriages?
If it's subclinical, the GDG says you don't have to treat. Yeah, that's interesting because I would treat as well. Hypothyroidism, then we're not sure. They say, you know, you have to treat because they have other symptoms. Obviously, they have typical, and if they have typical antibodies, then they say we need studies with the antibodies whether to treat or not. But usually a patient that presents with these antibodies, they have Hashimoto. And you might as well treat because they are associated with Hashimoto disease. Okay, management guidelines. So genetic counseling for abnormal fetal or parental karyotype. You don't really give antithrombotic prophylaxis with inherited thrombophilia unless if the patient has another risk of venous thromboembolism in the subsequent pregnancy. With antiphospholipid syndrome, they say you give low-dose aspirin before conception and continuing with the pregnancy. And once the pregnancy has been tested and proven positive, you start a prophylactic dose of heparin.